Okay, hello everyone, and welcome to yet another lecture in our lecture series on medical genetics in Pakistan. This is our ninth lecture, and we are very proud to have a collaboration between the Pakistani Society of Medical Genetics, the University of Health Sciences in Lahore, as well as Jinnah Sindh Medical University alumni in North America. I have some housekeeping rules for us to next slide, please, Ajaz. For us to look forward to, because everybody loves some housekeeping rules. Our audience will be muted out of respect to the. Go back,
I apologize. All right.
It's okay. Out of respect for our presenter today. And please, if you have any questions, either during or after the talk, please put them in the chat box, and I will make sure that I present those questions to our presenter at the end of his talk. And I will also be providing you with a link to a Google form, and I would really appreciate it if you could please fill out that Google form. That is the only way for us to keep track of who's attending and what the interest level is like. And so we're looking forward to having a large group of people who are interested in Pakistani Society of Medical Genetics and our affiliated events. So if you're ever interested in getting more information, please fill out that form and we'll be happy to add you to our email listserv. Next slide, please. And then without any further ado, it is my pleasure to introduce our speaker for the day, Dr. Syed Ajaz Ahmed. Dr. Ahmed is a molecular pathologist and a clinical geneticist at Kaiser Permanente, Southern California. He is a graduate of Dow Medical College and completed his clinical genetics training at the University of Miami and did his fellowship in molecular genetic pathology from Mayo Clinic. He is certified by the American Board of Pathology and American Board of Medical Genetics in clinical pathology, clinical genetics, and molecular genetic pathology. He has special interest in hereditary cancer genetics and has authored and co-authored numerous peer-reviewed journal articles. And now it's time for him to take it away. So rock and roll, Dr. Ahmed.
All right. Assalamu alaikum, everyone. And welcome to our talk. And thank you for spending your Sunday evening, Pakistan, with us. And it's a pleasure for me to talk about this topic. This is a very important topic as far as genetic counseling is concerned. I would say it's one of the pillars of genetic counseling, which is prenatal genetics. Most of the genetic counselors here started with doing prenatal genetics, and it blossomed into what we have here today with all cancer genetics and other genetics and lab genetics. But prenatal genetics is kind of the bread and butter for genetic counselors. And this is mostly handled by genetic counselors, not by physicians, but just in oversights. So before I start, I just want to make sure that I let you guys know that I have nothing to disclose and I have no financial gains from this talk. Also, before I start, I would like to acknowledge my colleagues, Jeff Greenberg and Jennifer Herr and Stephanie Morton. I had to put this talk together in a very short time, and they helped me with sharing some of the slides which I'm using in this presentation. So thank you to them. So what is prenatal counseling? It is when a couple seeks information regarding the risk of having an abnormal outcome of a pregnancy. It could be that they are not pregnant at this time and they just want to know if we have a baby, what will happen, and that's future pregnancy risk assessment. And generally it's put in preconception counseling. Or if they are already pregnant and they are worried about the baby and they have questions, and I'll talk about all the indications why those patients come to us. But that's post-conception. So preconception counseling is a little bit different than post-conception, because with the post-conception, you have a baby at hand that you have to worry about. Like I said, it's provided by genetic counselors mostly, where available with the oversight of medical geneticists. And they also work very closely with the, with the OBGYN doctors to provide such care. There are many different reasons why a couple would come to a genetic counselor to seek help. And this is a busy chart, but I've kind of divided into two areas. One is the reasons, the common reasons, I should say, for why patients come to preconception counseling. And the other side is why patients would come and see a genetic counselor for post-conception counseling. So let's talk about the circle on the left, and I will go in a clockwise manner. One important question that many parents have is sometimes they get married late, and especially here in the West, people are busy in their careers and women get married late and then they decide to have children. So advanced parental age is a very important question that people ask, because we know, and I will elaborate on it further later on, that advanced parental age, both mother and father, may be associated with some genetic problems. So that is one important question that they come and ask a genetic counselor, like, okay, we are planning to have a baby. What is the chance we will have a child with some problem? The other important question is teratogenic exposures. For preconception counseling, teratogenic exposures are usually when when the mother is taking certain medications, or say she has epilepsy, she has seizures, she's taking certain medications for that, or she, has a history of alcoholism or something like that. That is more common here. They kind of want to know if they conceive a baby during the time when they're taking a certain medication, what would be the consequences of that? Because some of the medicine, some of the chemicals can be detrimental for the developing baby. So that is a very important question they come and ask, and the genetic counselors go through databases and tell them that this is a certain medication, this is the chemical that you're taking, and this would be the effect of the baby. So you may want to stop the medicine before you decide to get pregnant and all of that. So that's important. The third thing is they may come because they have a personal history of a genetic problem. They may personally have a genetic condition that has been diagnosed, and they want to know, what is the chance for my baby to have what I have? If it's a recessive condition, you can counsel them accordingly. If it's an X-linked condition, you can counsel them accordingly. But that is important because they come to see. When they are children, they are told that you have a genetic problem, but they don't really understand to the time when they are ready to start a family. That's the time when they come in and say, this is our personal history, so tell us what is in there for us. Similarly, family history, so they don't have a personal problem, but rather their brother or their sister or their uncle have some kind of a genetic problem or intellectual disability. They are worried that, my uncle I have two uncles who have a problem. So what is the chance that I will have a baby who has this? So they're thinking of an X-linked condition. So that is a very important part of family history, where they come in and you really have to know exactly what's going on in the family to provide counseling. So many times the genetic counselors ask for records of the family members to get those records, go through them, figure out what it is. If they have not been tested, have them tested so you know exactly what it is. That way you can help the patient and let them know what is the chance for them to have a baby with that condition. Another important thing is consanguinity, which is more of an issue in Pakistan and other societies than it is here. But we still have a lot of immigrants here who have consanguineous marriages. And so two cousins are planning to get married, or they have married and they are thinking of having a baby, and they want to know what is the chance that they will have a child with some problem. Sometimes they already have a family history of a certain problem, and then they're worried about that. So consanguinity is big, and I'm going to talk more about consanguinity, so I'm going to stop there for consanguinity. The next one is a previous abnormal pregnancy. So a woman has had a child who was a baby who was abnormal in certain way, had a heart defect or had a kidney problem, or was a miscarriage or was a fetal demise. So they know that, the previous child, or maybe one or two children babies have had problems, and they don't know exactly what happened, why those babies had that problem that they had. But now they want to get pregnant and they want to know is it going to happen again? And that is when we have to get all the records, try to find out what it was, and then try to help them as much as possible to let them know what is the chance for them to have a baby with that problem. And then multiple miscarriages is kind of in the same category, where a woman has conceived multiple times, but they are unable to carry the baby, and they have miscarriages. So they are trying to figure out why that has happened, and if they can find out before they get pregnant again, what was the reason for their miscarriages, so they can avoid that. So those are important. So in this circle, you can notice that I have two things that are marked in a different color: the advanced parental age and the consanguinity. I will touch, I will touch on those topics more, and I will leave the others because otherwise this will just get too much. On the right side, with the post-conception counseling, is pretty much same indications, but there's just a different scenario right now. So again, mother is pregnant and she is, say, 45 years or 47 years old, and she knows that she's older and she wants to know, is there something wrong with the baby, because she knows that there's a higher chance for a baby to have a problem if they're older. So they come in and ask for some kind of screening test so that they can find out if there's anything wrong with the baby. Similarly, over here, all women go through a process which is called prenatal screening results. So they testing. So they, once they get pregnant, regardless of their age, they go through certain screening to check if the baby has any problems. That would include some biochemical testing, that would include ultrasound testing. And now there are other testing that are available that I will talk about. So that, again, you see the different color there. So I'm going to talk more about that. But if any of those screens are abnormal, then they come to a genetic counselor, and the genetic counselor have to work them further and do testing for them. And we've already talked about personal history. If they have a personal history, when the baby, they have the baby, they're trying to find out and get the testing done on the baby to find out if the baby has that problem. Similarly, if the family history is there, if there's a chance for the baby to have the same problem, they're trying to do some type of diagnostic testing, trying to find out if the baby has that problem or not. Previous abnormal pregnancy, same thing. Pre-implantation genetic diagnosis is one extra thing that I've added here. Which is, yeah, there is a baby, but it's not being implanted here. This is in vitro fertilization, where there's a baby or embryos in test tubes. Most of the time it happens because there is a known family history and they want to do some genetic testing on the embryo and only implant the embryo that is viable or does not have the genetic problem. So that's a different set of testing, and I'm not going to get into it too much, but you all should know that there is this option of pre-implantation genetic diagnostic or testing, where in some religion or cultures, the women do not want to terminate a pregnancy. So if they have the money and the means, because it's very expensive, they opt to do the in vitro fertilization, where they create many embryos, test the embryo at a very early stage for whatever the genetic condition needs to be tested, and then implant that embryo so that then that pregnancy goes on well. Teratogenic exposures, they're already pregnant, and the first 2, 3, 4 weeks before they knew that they were pregnant, they were partying and, you know, alcohol or other drugs or anything like that, or maybe medications, whatever it was. So they want to know if there's any teratogenic effects on the baby, and that is why they come, and, you know, most of the time you have to do ultrasound and stuff like that to see if the baby has a problem or not, or you just tell them, no, the exposure was not enough, so you should be okay. So again, I will touch on advanced parental age here, consanguinity here, and on the other side, I will talk about the screening test, and then we will go from there, from the diagnostic test. As far as the advanced maternal age is concerned, there is a higher risk for chromosomal abnormality. With the advanced maternal age, as the mother's age advances, there is a higher and higher and higher likelihood of having a chromosomal problem because of the meiotic disjunction. This is a table from New England Journal of Medicine. It's a pretty old table, but still valid. So you can see if the woman is 20 years old, for her to have a child with Down syndrome is about 1 in 1,480. And any chromosomal abnormality, which is not just Down syndrome, but anything else, it's about 1 in 525. And as you go further down, when you get to age 35, the risk for trisomy is 1 in 353. And any chromosomal abnormality is 1 in 178. Over here in the US, kind of the cutoff for what we call AMA, advanced maternal age, is age 35. So a woman, if she's 35 years and older, the risk is high enough to offer her diagnostic testing or screening testing. Screening is offered to everybody, but diagnostic testing like amniocentesis and CVS, which I will talk about, that kind of starts here. So 35 and older, and you can see if she's 45, the risk for chromosomal abnormality is 1 in 18, which is very high. And for trisomy 21, it's 1 in 30. So that's pretty high as well. So that is something important to keep in mind if you have patients who are of advanced maternal age. That is something that you need to talk to them about. As far as the advanced paternal age is concerned, some people use 40, some people use 50, but this is an excerpt from the Mayo Clinic from the Mayo Clinic website, which I extracted, and they have all the references there. But when a father's age is over 40, we don't have problem with chromosomal issues. We rather have problem with point mutations in certain genes, or certain genes would be affected. So because of that, there's a slightly increased risk for pregnancy loss, slight increased risk of rare birth defects, again, for point mutations. Autism is a higher risk. It has also been linked to schizophrenia in children, and also with leukemias. This is a very soft thing. There are not too much strong data about this, but there are papers who have linked advanced maternal age with point mutations and things like that. So remember, I told you that I will talk to you about consanguinity, and the reason I want to talk to you about consanguinity is because this is a very important topic as far as Pakistan is concerned. And we have done so many clinics in Pakistan, and again and again and again, we have seen consanguineous families that come through that have children who have certain genetic conditions. So this is very important to understand and for you to talk to your patients about. This is a very busy slide, but basically what it is telling us is what is the amount of DNA that we share with our relative. So if you have a brother or a sister, you can see on the left, you share 50% of your DNA with them. If you have a father, your father, again, you have all first degree relatives, you have 50% DNA that you share with that. As far as your uncles and aunts are concerned, you share 25% of your DNA with them. And further down, your first cousins. And the first cousins are very important because most marriages are between first cousins or second cousins. They share about 12.5% of the DNA, and the second cousin, you share about 3.125% DNA. As you go further and further down, the amount of DNA you share with your relatives gets lesser and lesser, but it's still, these numbers are there. So you do share some amount of DNA with them. And when you share some amount of DNA with them, that means if you are a carrier of a certain gene, there is a higher chance that they might be a carrier of that certain gene problem. I came across this paper by Hussain and Bettles, which was published in 1998. And it talked about the prevalence and demographic characteristic of consanguineous marriages in Pakistan, and was published in Journal of Biosciences. They looked at about 10,000 women there. And they said that approximately 60% of the marriages that they found were consanguineous in Pakistan, and over 80% of which were between first cousins. So which is a pretty high number. And I think Pakistan has one of the highest level of consanguinity, consanguineous marriages in anywhere in the world. So their coefficient of breeding is high. That means the amount of DNA that the people share between themselves is pretty high. And they also looked at other papers, and they kind of said that data, the 60% consanguineous, is unchanged over the past 3 to 4 decades. So, this was 98, and I don't know how much difference would have up till now things would have made, but I'm thinking that it's pretty much something closer to this or maybe higher, who knows. So this is an important thing to do. But, the important thing is we all have family members. We all have family members who we know are married to their cousins. And this is the reality. If we are from Pakistan, we definitely know somebody who is married to cousins, or maybe we are, somebody in the audience is too. And it's not always a bad thing, because many times they have healthy children, they have good children, and but you have to keep in mind that there is a possibility. And now there are carrier screening that are available for certain genetic conditions like thalassemias and others that can be done. And we have contracted with certain labs in Pakistan, and there are some doctors over there who are already sending these tests. I did not want to name any lab, but if you want to look at labs that do this testing, you can just go to the GTR, or Genetic Test Registry. You type it expanded carrier screening, and they come up with all the different type of laboratories that are available for screening. And I don't know, there could be logistics of finding a lab that would work with Pakistan, but there is this carrier screening available. And in certain ethnicities over here, like Ashkenazi Jewish and other population, if a boy and a girl want to get married, they first have to go through the screening to find out if they have common genes that can have, that they can have affected babies. And once they're cleared, then they can go and get married. So this kind of testing is available, and especially if you have a family history of certain genetic disorders, and you can find out if that testing covers that, and then can get tested for that. Recently, a paper was published by Screening for Autosomal Recessive and X-linked Conditions During Pregnancy and Preconception, a practice resource by American College of Medical Genetics and Genomics. I've put the link to that. If you guys want to read about it, please go ahead and do that. This is a good paper. This is as recent as you get. It's 2021. And they have screening recommendations for patients. So the important, now I'm switching gear and I'm going, so we've talked about advanced parental age, and we've talked about consanguinity, and now I'm kind of going into the other circle. Remember, I told you I'm going to talk about the screening test and what it means and how we do the diagnostic test. So the important thing about the screening test is to remember that they are screening tests. They are not diagnostic tests. They do not diagnose a condition. They're designed as such that they have a high false positivity rate because they want to capture more people, and they're designed to screen the population at a higher risk. Patients who have the abnormal screening then are offered the diagnostic test. So if you're screen negative, most of the time you're not offered a diagnostic test unless there's a very high clinical suspicion. But if you're screen positive, then those patients again come to genetic counselors. Many of the screening tests are done by OB doctors, so they are not here yet. They are offered by the OB/GYN doctor. They go through the screening. If the ultrasound is abnormal, or a biochemical test is abnormal, or other tests are abnormal, then they are sent to a genetic counselor, say, hey, this patient tested positive for this, so could you take it from here and find out if the baby is affected or not. So the diagnostic tests are important. They are more definite, they're more diagnostic, they're more sensitive. As far as the screening tests are concerned, different countries have a different screening testing, and I'm not exactly sure what we have in Pakistan, but I know that Pakistan on a routine basis does not have a screening program. There are certain OB/GYN doctors who do certain type of screening. That's all privately done. But the screening, some of the tests that you can do with the screening is, the simplest test is just to do a CBC, or a complete blood count of a patient. And in that, important thing is to see what the MCV is, mean corpuscular volume, and I'm going to elaborate on that further because it's important from the Pakistan standpoint of view. Other than that, cystic fibrosis carrier screening is done. Spinal muscular atrophy screening is offered here in the US. Sickle cell anemia, because it's more common in African American population, that's offered to patients here. ethnic-based screening, if the patient belongs to certain ethnicity, like I told you, Ashkenazi, Jewish, and other, where they have more common Tay-Sachs conditions, cystic fibrosis, and other conditions. If you belong to that ethnicity, then they give you that expanded carrier screening test. First trimester screening, medical students who are on the line here, they know, they have read it in their OB books. What is first trimester screening? What is second trimester screening? It is still being done, but I assure you it'll be gone in the future, because it was a good test till the time we have newer tests that I'm going to talk about. Also, ultrasound is a screening to look at nuchal translucency or other birth defects. And then the newer test that I want to talk about is non-invasive prenatal tests. So again, the circles on the left side, which have the different color, is what we're going to talk about. And we're not going to talk about cystic fibrosis screening, spinal muscular, sickle cell screening, but I will address the other ones. So CBC was the one that I told you is a very simple test. It can be done at any laboratory in Pakistan. And it is a very good test to screen for, to at least start screening for hemoglobinopathy, especially thalassemias, which are very common in Pakistan. Fatmi thalassemia, this and that. So this is a very simple test. You do a CBC, and in the CBC, you especially look for the MCV, which is mean corpuscular volume. And if the MCV normal range is 80 to 100, if it's below 80, there should be a little red flag there. You may want to go into the history and see if the patient ever had a MCV over 80. If she had it over 80, then don't worry about it. But if she never had it over 80, every time it was 70, 72, 73, then you first wonder if the patient has iron deficiency anemia, which is again a really common thing in Pakistan because of the dietary condition. And so you may want to check for the iron deficiency anemia, check the ferritin levels, check the iron levels. If those are normal, then you're like, okay, so she has a low MCV and she has a normal iron level, so something else might be going on. And it could be that she's a thalassemia carrier. Again, carriers are okay. She may have a trait. So the easiest thing to do next is just screen the partner, see if the partner has a low MCV too. And if the partner has a low MCV, then you're like, okay, now you have both parents who have low MCV, so they both can be carriers. And that would be the red flag. And, of course, you have to rule out iron deficiency anemia in the partner as well. And once that's established, then you can work them up for hemoglobinopathies and try to see if they have thalassemia. So this very simple, easy, cheap way to find out if a couple may have a risk to have a child with hemoglobinopathies. This is a busy slide, and I apologize for that, but this is, I don't want to spend too much time on it. This is basically what we call it first trimester screening and second trimester screening. This is all biochemical testing, which checks in the first trimester for human chorionic gonadotrophin, PAP-A, which is a biochemical marker, and it also checks for AFP. And depending on the ratio, they calculate multiple of means of these chemicals, and depending on the ratio, that can give you a sense that this baby may have a higher risk for trisomy 21 or a higher risk for neural tube defect. And there are many different ways this test has been used. They have done first trimester screening, they do the second trimester screening, where they add the inhibin to the unconjugated estriol. And there's an integrated prenatal screening where they include all of this plus the nuchal translucency together. So the sensitivity and specificity of combining these tests become higher and higher, but it's nowhere close to what the test we have now, which is called non-invasive prenatal test. The advantage of this testing is that it looks at AFP, and that kind of is a good indicator. If it's high, right in the middle, you have a higher chance that the patient may have neural tube defect. So that is an important thing to know, but otherwise this test is kind of still being done. and I'm sure it's being done in Pakistan, but it's going to be obsolete. That's my own opinion. And just to go back, these markers are also very time sensitive. You have to get done at the right time, because if you don't do it at the right time, these markers can go up and down, and you may lose the sensitivity of the test. So it has to be done at the right gestational age to have the right calculation. So that's also a very big variable here. I don't know why I have this line there. The other thing that is done is screening is translucent, nuchal translucency. And this has to be done by very trained professionals. And I know we have Dr. Shama Muneem, who's our fetal maternal expert in Pakistan. She's on the line. Basically, what they do is they check to see the nuchal. Nuchal is basically the neck and the edema in the neck, how much there is edema. So if it's 1 millimeter or less, like it's shown here, then you're good. But if it's higher than that, and if nuchal thickening is higher, then that could be suggestive that there is something wrong with the baby, and trisomy 21 or Turner syndrome or cystic hygroma, or other chromosomal problems could be the case. So this is again a screening. If you have something like that, it's a red flag that needs to be further investigated if there is something going on. So as far as the ultrasound is concerned, again, like I told you, it's a screening test. Here, many women get it at 18 weeks of gestation. They get a very detailed ultrasound by their OB doctors, who check the heart to see if there are any heart defects. They measure the bones, look at the skeletal to see if they have any skeletal dysplasias. Also the spine to check if there are any neural tube defects, the head, if it's growing properly, kidneys, abdominal organs to see if they are okay, or if there are any abdominal wall defects. So if anything's wrong here, then you're like, okay, something's not right. The baby has a problem, maybe a genetic problem. Go see a genetic counselor. They will talk to you about the diagnostic testing, and we'll try to figure out what's wrong with the baby. So those are all screening up to now, the biochemical screening, ultrasound screening. These are the defects that you can see, which is neural tube defect, anything to do with the formation of the neural crest. And sometimes the brain doesn't form, and those babies have anencephaly, and this is basically lethal. The baby's just not going to survive. And sometimes we have to do the heart counseling of telling the mother that this baby doesn't have a brain because the brain did not form properly, and it's anencephaly. Or they may have these spina bifida. The spina bifida could be very variable. Sometimes they're as big as this and cause a lot of problems. Sometimes they are very adult spina bifida and very, very small neural tube defects. So depending on what it is, you counsel the family and give them that information as to what they're needing. Abdominal wall defects. On the left side, you can see a full defect in the wall. So the wall did not even close. In the middle, there's a big omphalocele. So from the umbilicus, this is the whole thing, gut that has come out, and it's like a hernia. It's an omphalocele. And different things denote different things, different genetic conditions. So if the baby has it, then you counsel the baby accordingly. On the right side, you have a baby who has gastroschisis. That means all the gut is outside the body. And this also is a pretty common thing that we see in our practice, that we have to counsel the family. These can be repaired. It can be taken care of. Surgery can be done, but families get worried as to what's wrong with the baby. So this is important for us to know. This is the most important test that I would want to talk to you about, because remember I told you that the biochemical testing is going to go obsolete. This is something newer that has come on. We are very excited about it. It happened about maybe 3-4 years ago, but now it's become so mainstream. It's called non-invasive prenatal testing. Basically, the reason why it's called non-invasive is because you do not have to do anything with putting a needle in the mom and trying to find out what it is. This is done on mother's blood. So like just a regular blood test. What they do is they look at the plasma, which is the cell-free part of the blood. So basically, when you have a woman, she has a baby, the fetal DNA leaks from the placenta into the mother's circulation. So it is present in the mother's circulation. So say this is orange, this is blue. And then when you check the mother's blood and you take the plasma, which is the cell-free part of it, you see fragments of DNA. And the fragment of DNA are mixed DNA. They are mother's DNA, and then there's fetal DNA. And what you can do is you can compute the amount of DNA there is, do massive next-gen sequencing, and basically there are algorithms and then there are calculations where they finally can tell you what is the ratio of the maternal DNA to the fetal DNA, and if there is extra fetal DNA or less fetal DNA. And this has a pretty high sensitivity. This test can tell you with almost 99% that if the baby has Down syndrome or trisomy 18. And they also look for other aneuploidies. They can tell the sex of the baby, if the baby's a boy or a girl, depending on what it is. And they are now also looking to see if there are small micro deletions or duplications that are adding to this test. So this test is becoming more and more and more available. Right now, we're still doing it for women over 35, but there are many centers here in the US that are doing it for women who are less than 35 years and older. It's a very sensitive test, but it's important to understand that it is still considered a screening test. I have seen many patients who may have a false positive test, and when we do an amnio CVS, it does not show what this test shows. And it is not a very good test for twin pregnancies either, or some other pregnancy complications. So it's important to understand that if this comes back positive, you don't tell the patient, oh, your baby has this. You just say, there's a very high chance your baby has this, but we would like to do an amniocentesis or a CVS, which are diagnostic tests to say for sure if the baby has it or not. This is just a paper that I just put in, which is non-invasive prenatal testing technologies, clinical assay, and implementation strategies for women and healthcare practitioners. Very easy to read paper. If you really want to learn about what is NIPT, non-invasive prenatal testing, this would be a good one for you to read just to begin with. But then there are many other papers that are out there. And all of this information, of course, is going to be on PSMG website. So we'll get into the diagnostic procedures. Basically, the diagnostic procedure is trying to get a fetal tissue, right? Because we know that something's not right with the baby. You want to find out by doing testing on the baby. So how do you get the baby's tissue? The two common methodologies are chorionic villi sampling, and the other one is amniocentesis, where you take some amniotic fluid out of the babies. CVS basically is a procedure that can be done earlier. It's done at 10 to 14 weeks of gestation. You do have an ultrasound probe, and an expert person like Dr. Munim, who's on the line, would insert a needle through the vagina, get into the placenta, because the placenta has fetal tissue, especially the chorionic villi, and extract a piece of the chorionic villi and then send it for testing. Because you're looking at the tissue, you may not be able to detect neural tube defects or do AFP testing on it. And the miscarriage rate is about 0.5%. So more than 99 women would not have any complications. It also depends on the person who's doing it. And the important thing here is sometimes you get contamination from the maternal cells, because you are going through the maternal tissues, and for certain testing, you want to make sure that the maternal cell contamination has been ruled out. And there's also a chance that sometimes the tissues may give a different type of chromosome count, because something that we call confined placental mosaicism. I won't get into that, but this is a good test that can be done earlier. Amniocentesis, on the other hand, is basically done later on at 15 to 20 weeks, where there is more fluid in the body, and you put in a needle and you basically suck the amniotic fluid. And amniotic fluid is basically baby cells floating in, because it's maybe just going through the baby, and the urine that baby has is what amniotic fluid is. It can be done at 50 to 20 weeks. You can do chromosome analysis, greater than 99% sensitivity. Neural tube defects can be looked at as well, because you can check the AFP. You can do targeted DNA testing for whatever genetic condition you want to test for. And the miscarriage, like I said, is 0.5%. It's pretty low. So once you have the tissue, either you get it from CVS or you get it from amniotic fluid. Best thing is to send it to a laboratory that does cell culture. So they grow those cells. That way you have many of those cells, and those cells can then be used to do a karyotype, look at the chromosomes. Many labs over here are not doing karyotype anymore, or maybe just doing karyotype on a few cells, and they have gone to just do a chromosomal microarray. Chromosomal microarray is basically a karyotype on steroids. So you look at many deletion duplications and any other, deletions and duplications that could be there. But then there's a problem with variants of uncertain significance and all that. But once you have the tissue, you can do whatever you want to do with it. You can do targeted DNA testing for the family history. You can do biochemical testing if you want to do. Or if you really don't know what's wrong with the baby, you can even order whole exome sequencing and get that done as well. So sky is the limit once you have the tissue. But obtaining a clean, proper tissue and culturing it and having viable cells is very important. And there are labs in Pakistan who do that, and they can culture the cells, and then they can send those cells to the outside laboratories where this testing can be further done. So that's about the screening and the diagnostic procedure. So once you do the diagnosis, you may find a child who has Down syndrome, or you may have a baby who has a Down syndrome, or a baby who has a lethal condition like anencephaly or something that you finally have a diagnosis. It may be not so subtle, or it may be subtle. The important thing is, what do you do after that? And that is where the genetic counseling is the heaviest. That is where, where it has become very important for what we do is what we do and how we help the patient. So this is a take-home slide. When you talk to the patients, even if you're a doctor or you're a student there, or you're a genetic counselor or training to be a genetic counselor, once you have a diagnosis, it's very hard for the parents to know what their baby has, because everybody is happy when they get pregnant. They have a lot of expectations, and a lot of Mubarak Badis come in and everything happens. And this is a celebration, as we all know it. But when you end up finding out that there's something really wrong with the baby, that it's devastating for the parents. So it's very important to provide psychosocial counseling, support, hold their hands, talk to them, break them the news, tell them what's going on, and most importantly, explain to them, give them information about what that condition is. Maybe it's a recessive condition that runs in the family, and they may have seen some other person in the family, or a dominant condition. But you have to really provide them with medical information. You have to tell them what the clinical outcome is. Is the baby going to survive after birth? If the baby is going to die in utero, or if the baby survives, what will be the outcome? Is he going to be a normal person, or is he not going to be a normal person? All of those things are very important to tell them and not shy away from it, because all of that information will help them to decide what they want to do, if they want to continue the pregnancy or they don't want to continue the pregnancy, if they want to have more babies. You have to give them, explain to them the available options. You got to tell them, hey, so you have a baby who has this is what the condition is, this is what can happen. This is, so what do we do, doctor? What should I do now? And you explain the option, depending on what the gestational age, they may have the option of terminating the pregnancy. If it's a lethal condition, the baby is not going to survive anyway, then they may want to decide to terminate the pregnancy. Or sometimes they just say, oh, you know what, we'll just go ahead and continue the pregnancy. Or if there are any surgical procedures that can be done, even while the mother is pregnant, which happen here. I don't think there's much in Pakistan. All those options are something that you explain to the patient. And the most important thing, and I repeat it, the most important thing, you do not tell them what to do. It's a tendency in Pakistan to tell patients, you know what, आपके बच्चे के साथ ये problem है, I think आप जाके ना ये बच्चा जाया करने or you terminate the pregnancy. Do not do that. Don't tell them what to do. It should be very non-directive counseling. You respect the parental autonomy. You give them the option and let them make the decision for themselves. They may continue to ask you, Doctor, aap batao hum kya kare? Doctor, aap batao hum kya kare? Tell us what we need to do. Because they don't want to have this guilt of making a decision by themselves. Rather, they say, doctor told us to do that, so we did this. It's a very difficult situation in many different places, but this is the most important thing in genetic counseling, where you do not tell them what to do. You just tell them what it is and let them make the decision, because they have to live with it the rest entire life, and you don't want to be the one who should be blamed that, oh, I did it because that doctor told me to do this. That's important. And then you provide recurrence risk counseling. Of course, you tell them, okay, this has happened now. What is the chance for you to have a baby with the same problem in the future? What can we do about it? Can we do earlier testing, or maybe IVF or PGD? All of those options you provide them. So this is a whole complete thing where you start from the screening, you do the diagnostic, you try to find out what's wrong with the baby, talk to the parents, tell them, and you basically hold hand and help them. This is a huge part of the medicine, which I hope will become more commonplace in Pakistan. And we are trying our best from PSMG to bring genetic counseling to Pakistan and train genetic counselors who would be available to do all of this there. With that, I will stop. We have 10 minutes or so in time, and I will take any questions that you may have or any discussion that we can have. Actually, we have some time to have some discussion as well.
Thank you so much, Dr. Ijaz, for that amazing presentation. And again, I want to thank you and your colleagues for putting it all together at such short notice. And again, wonderful work there. There are a lot of excellent questions that have come through the chat, so I think we'll have plenty of great discussion. So thank you to all the participants that were so patient with us today, and we can get started with the questions. First question is from Seher Altaf, and I did a little bit of homework while you were talking about this, Ijaz. So if you would like me to add to your answer, I would be happy to add some.
Oh, by all means, anybody can chime in if I don't have the correct answer or I may fall short. So please.
Oh no, I'm sure you would be great. Okay, so the question is how screening programs work in the United States. Is it done for all the pregnant women in the United States?
The answer is yes. So all women who get pregnant go through a screening process. They go through prenatal intake nurses, as we call them. They have a questionnaire. They go through a little bit of family history, and then they are offered just the basic test, like I told you, cystic fibrosis, spinal muscular atrophy, and all that. And like I showed you that paper that have come with screening guidelines, they keep changing. This is a moving target. They keep changing. But as it happens, the short answer is all women go through a screening process. Some may go through an extra screening process if they have a family history of a certain thing that we know of, but otherwise generally everybody gets screening.
Yeah, that's pretty much what I have as well. The only thing I would add is that in certain parts of the country, more so than others, there are people that would decline prenatal screening, again, for religious reasons, where they would say it doesn't matter to us whether the fetus has a concern or not, it will change our outlook on the pregnancy, and so they decline screening. So there, but a very large majority do not decline. So it's offered to every single woman in the United States. Not every woman would take up on the offer, but a very large majority do. The next question is how, this is from Dr. Saqib Mahmood, and he wants to know how to screen for spinal muscular atrophy prenatally. I think that's one you can take.
Yeah, so it's basically it's a recessive condition. So you basically check the mother to see if she has if she's a carrier. So it's a carrier screening for the mother. The most common is for exon 7 deletion. So there is if the mother comes back positive, that means she's a carrier. Then we offer testing to the father to see if he's a carrier too or not. If both parents are carrier, then we know it's a recessive condition. It's going to be a 25% chance. And then a diagnostic testing is offered for the baby. So basically, you're checking the mother's blood to see if the mother is a carrier of cystic fibrosis or not. Sorry, SMA or not. Hope that answers your question.
Yeah. The next question is from Sahar Altaf, and she would like to know what is the ratio of abnormal screenings and is it common in the United States? The second part of her question is how do we counsel such patients and do you give options for what to do next, like abortions? I think you covered a lot of it during the talk as well. I'm happy to give some stats if that will help.
Yeah, it's a very loaded question and it's a very good question. So basically, the ratio of abnormal tests, I can't tell you because there is, it's a screening test. So yeah, we see it very often where the first trimester screening or the second trimester screening or the integrated screening will come back positive. And yes, if it's positive, then we do, that's what I said. They go to the genetic counselor and they tell them that your screen is positive. This could mean this, this, this. So you have these options if you want to use, but you have to tell them the sensitivity and specificity of these tests as well. But whatever it is, and you have the option of doing either NIPT testing or you can do a diagnostic testing if you want. So that's pretty much what happens here. And Aisha, am I missing anything in that question?
Yeah, so I'll just add the stats. So if we're looking at just the incidence, for example, of, I'm just gonna pick Down syndrome for the sake of simplicity here. So according to the UCSF, this is the University of California, San Francisco website, the incidence of children being born with Down syndrome is 1 in 1,000. So if you think about that, and you know that the positive predictive value of a screening test is, let's say for this first trimester screening is about 80%, you know that if 1,000 women were getting tested, one of them would be positive 80% of the time. I don't know, that's a little convoluted, but if that helps with any stats, I hope that was helpful. And of course, as Ajaz already mentioned, the age factor is pretty significant. As the female gets older, the chances of having a positive screen gets higher. And then as far as do we give options for abortions? So again, going back to Ajaz's point of very, very well said, which was non-directive counseling, which is to guide them to make the decision that's best for them. And if that leads to the termination of pregnancy or continuation of pregnancies, genetic counselors are very, very well versed in both of those directions. They would provide, let's say, for the sake of example, for Down syndrome, there are numerous organizations in the United States that are parent-to-parent organizations or Down syndrome support groups for children and parents and things like that, that we could, and we do refer them to if they are so interested and want to prepare themselves, and also make sure that the doctor, that the care is switched for from an OB to an MFM, which is a specific high-risk pregnancy situation. Also, the delivery is being conducted at a location where a NICU is present in case the baby will have any concerns. In terms of, we know that, correct me if I'm wrong, that almost 10% or so of children born with Down syndrome will have a heart defect. Please correct me if I'm wrong. I could be wrong about that completely. So scratch that. Maybe I don't know.
Yeah, it could be anyway.
But a small percentage are born with heart defect and may require surgery and things like that. And so, you add all of those complications into the counseling. And then, yes, if the couple or the parent is not interested in continuing the pregnancy and have decided that it is not the right time or situation for them, then yes, we do, of course, if the state allows, of course, states states like Texas have recently banned any abortions after 6 weeks. So we can't obviously do that because the state does not allow us to do that. But so for genetic counselors that are living outside of the state of Texas, we'll be able to provide counseling on how to proceed with a termination of pregnancy as well.
One thing I just want to make, you asked about screening tests and you said giving them the option of abortions. Please remember, screening tests
Okay, yeah.
are not something that you talk to the patients about terminating a pregnancy. Important to understand, from screening, you have to go to the diagnostic testing. Once the diagnosis is confirmed, then you talk about those options. So do not jump from screen positive to a termination of pregnancy. Do not do that. That's a big mistake.
Excellent
Agreed,
point.
Dr. Ejaz, if I can say something.
Assalamu alaikum, Dr. Muneen. Thank you for joining in.
Walaikum Assalam. From Pakistani perspective, I just want to add that when we offer nuchal translucency screening and somebody is screened positive, everybody jumps and gives them the option of termination, and going sort of reiterating what you've already said. What we do in our counseling is the diagnostic testing. Then if that comes back normal, then we offer them a fetal echo, because raised nuchal translucency can be a marker for chromosomal abnormality and cardiac defects and genetic syndromes. And more so when the nuchal translucency is more than 4, then when I was working in UK, we used to send for Noonan syndrome also. I'm not sure what is the practice in the US.
We do.
Yes.
We do also think about many different conditions, and we just go down the list after CGH is normal. And if there's a heart defect, like you said, yeah, Noonan is next on the list. Any other questions, Aisha?
Yes, multiple other questions. Okay, so this one is more of a technical question. So the question is from Hira Iqbal, and she wants to know how aging of mother increases the chance for chromosomal abnormality in her baby. So it's non-disjunction.
Yeah, so I'll try to give the answer to the best of my ability. The thing is, for the woman, you know that the eggs are stuck in the premeiotic stage, and then they mature as the woman ages and the cells go through the meiosis. So as the eggs get older, and I wouldn't say mother gets older, the eggs get older as well. There's a higher chance that the maturing egg would not mature in a proper way. This is a very simple answer that I'm giving you, and that causes that egg to have an abnormal chromosomal count. And that is the reason why, with the advanced maternal age, you have a higher risk for having an abnormal outcome. It's not because of the mother, it's because of that egg has not matured properly and has a chromosomal abnormality in that.
Yeah, if you're interested more, Hera, you can also look up the term non-disjunction. So that will help you. We don't have the visual aids to show at this time, but really it's how during the mitotic stage, how the chromosomes split, and that causes a problem in non-disjunction, and that will help you understand the concepts a little bit more. The next question we have is from Rabia Faridi. And Rabia wants to know, are there any metabolic diseases being tested for as part of screening in Pakistan? And we have a few more questions.
It's a very good question. First of all, I'm not well aware of what is happening in Pakistan. I know Pakistan doesn't have a universal screening across the board, but I'm sure in certain families where they have a metabolic problem going on, there could be some biochemical screening that can be done on amniocentesis or the cultured cells. But it's not a universal screening, that I know for sure. And anybody from Pakistan can chime in and tell me if there's any universal screening. But as far as I understand, it's more family specific if there's any particular disorder that they want to screen for.
Yeah, we have both Dr. Shama Manim on the line who might know a few things, and also Dr. Chima. Dr. Homa Chima is also on the line if either of you would like to unmute yourself. for a quick response.
Ji, Assalamu alaikum. This is Dr.
Well-
Professor Homa. Thank you so much for your talk. Sorry, I think my lecture last month because I wasn't well and I couldn't take it, and that would have talked about the metabolic defects in Pakistan. We don't have a universal screening in Pakistan at all. We wish we would have. In few places like Aga Khan is trying it. Some hospitals are doing a small project of newborn screening, and this is done by a family from Jordan who had a child with a metabolic disease, and think there's the Ali Zaib Foundation. So they do offer it to some private hospitals. So it's not a universal thing, but when we diagnose families with the common metabolic disorders that we have, among the organic acidemias, methylmalonic, propionic acidemias is a pretty common disorders. So any of these disorders which are diagnosed, and when we have done the genetic testing, we do offer then the prenatal testing, the CBS at 12 weeks. So we do the CBS at 12 weeks, and we then sort of counsel the family. So this is not a routine thing, but targeted. Routinely, no. Hypothyroidism and all is checked also not routinely and is in some private hospitals. We have put up this proposal to the Punjab government, and I think AKU is trying quite a bit as well to have some sort of neonatal screening, and Punjab government took the names of the common metabolic disorders from us, and we gave them a list which would make a major difference with screening as a newborn screening program. I don't know what will ultimately come of it, but it's supposedly a plan in the future, if that answers your question.
It's thank you so much, Dr.
Can I
Chima.
add
It's good to
something?
have you. Good to have you
Can I add something?
on board. Sorry, just one thing I want to add, and whoever was saying can say. So there are two things. One is prenatal screening, and the other is newborn screening, and they need to be kept separately. And
Yeah,
yes, the
it's
newborn screening is what we were talking about. That will be offered to all babies that are born, and prenatal screening
Yeah,
is
the
what's offered
neonatal
to
screening, yeah, that is not offered. That's why I told you before that Ali Zaib Foundation offers, it's a bunch of diseases, and this is actually, the testing is done in Jordan, I think. So this is like the 21 hydroxylase, thyroid function, some of the organic acidemias, urea cycle defects. They take this filter paper from the newborn, but this is a few select hospitals. We do that also at Children's Hospital. We are using the Ali Zaib Foundation. So PIMS does it. So it's not a universal thing. That's why I'm saying we do a targeted testing of the family, or if there is a history and no child is alive, we will take the test for the newborn baby. We'll take the cord blood at the time the baby is born. So this is targeted. Universally, no. But this foundation is offering in many hospitals actually free of cost.
Can I just add something? And
Please.
the Indus Hospital has recently started newborn screening, and they have a comprehensive panel. So they have started doing it. But offhand, I don't remember which ones they are doing, but they have quite a few tests that they are offering to high-risk women.
Assalamu alaikum. I'm Hafsa Majid from Afan Hospital. So we are currently offering high-risk screening for organic acidemias, amino acidopathies, cystic fibrosis, key diagnostic screening, and inshallah in 1 month we'll be able to offer fatty acids, galactosiemias, and one other metabolic test. I don't remember, the peroxisomal screening for peroxisomal disorders.
So
inshallah.
this is all for newborns, correct?
Yeah, this is all for newborn. For prenatal, we are only doing the triple screening test, and inshallah, we'll be offering the trimester 1 test in a few months.
This
Thank
is
you.
Dr. Rizwan Naeem. So from AKU, Hafsa. So my question is, how many tests of the prenatal screening, biochemical screening do you do in a year, for example, right? So question is, how many pregnancy versus how many screening tests?
So it's not done in every female. So I know the stats of a poster. It was done by one of my colleagues. So she presented data of 8 years, and in 8 years, 1,500 women were screened for Down syndrome by triple test, and 250 of them came positive.
But you're right, absolutely.
8 years.
But what I'm saying is that's a very minimal number if you look at number of pregnancies. And
Yes.
then out of 250, you have a lot of what you call false positive there also, because it's a very high false positive rate for biochemical
Yes,
screening,
I agree.
right?
I agree.
Right. So
Yeah,
as
agreed.
Ejaz said, that test is obsolete now, and there are so many problems in big picture that it gives more anxiety rather than any relief.
I agree with you, completely agree with you, Rizwan, on triple test and being working in Aga Khan up until recently. I think we have almost abandoned the use of triple test for the last decade or so, because I think it's usually done by people who are working outside AKU, mainly who don't have access to nuchal translucency, and largely the nuchal translucency has replaced the triple test because of the screen positive, high screen positive, as well as only the 65% sensitivity.
Right. So just for all of the audience, this group has also looked into what is the best way to do, like, let's say, non-invasive prenatal testing. And if I'm correct, you can get it done in $99 by Invitae. Is a company in US, and you just send your sample in and they'll give. So that's positive predictive value is almost 99%. They are correct, almost 99% for Down syndrome and trisomy 18 and 13. More importantly, 18 and 13 can easily be diagnosed by ultrasound. And then the only reason left really is open spina bifida, which AFP from blood can do it basically. So I think this biochemical test has no value, especially in ethnic population where means and moms are not established in Pakistan. So you are still comparing those means and moms from Western studies, which has a very different ethnic and biochemical background.
Dr. Hafsa, if I can ask you, you said newborn screening you have implemented in Aga Khan. Are you doing it free of cost, or are you charging the baby, the family for it? And what is the cost of this newborn screening?
So newborn screening, as in a program, we have launched it only for the two endocrine tests, congenital hypothyroidism and congenital adrenal hyperplasia. And the cost is bear by the patient.
So this
And,
is not really a newborn screening, because I mean, I thought organic acidemia you thought was included.
No,
so
it's not
galactosemia is not.
included. No, it's not included. It's done for the high risk patients only. When the
So there is, if there is a family history, if there is a family history, then you do not do a CBS, you will do only the newborn screening? What do you mean by high risk for organic acidemia and urea cycle or any such thing?
By high risk, I mean, if the patient have signs and symptoms, then the physician sends us a sample.
If the
So
baby,
that's not newborn screening, that's a diagnostic.
Yes,
That's
it's not
a
offered to
neonatal, it's a sick neonate getting a testing, no? That's not newborn screening. The thing
No, it's
about
not.
what, yeah,
Newborn,
so
we are only doing CH and CAH, congenital hypo and adrenal hyperplasia.
yeah, well, that's not really new. But what we were talking about is what we have put up to the government. And I thought at that time when Aisha Habib spoke to me that newborn screening at Aga Khan will include other disorders which are common and which can make a big impact because it's a life and death thing. So
Yes,
now
that
I
is
understand.
pipeline,
Yeah.
because we cannot introduce anything in newborn screening program unless we have a confirmatory test available.
if I
Because
may
we-
interject, the newborn screening is a different topic. Today we are talking about the prenatal screening, and I don't want to mix that. And hopefully next week we will have this talk.
Sure.
Next month we will have this talk on metabolic. so we can talk about the newborn screening, which is a huge topic for Pakistan, and inshallah, hopefully something will be implemented nationally and we can start that. But I don't know if you've still got questions about the prenatal, we can address that for now and then keep
Just
the
one
newborn
thing which I
screening.
put up for you as well, that you said in Pakistan, they're telling quickly about termination. I sort of like a little disagree with that, because, termination is still not legally allowed. So basically, we would talk less about termination in Pakistan. We would more likely just counsel them, because unfortunately up till now I'm still trying with the pediatricians to get this law, and this needs a lot of work done, that we have a law which approves that if it's a lethal disorder, the muftis have agreed, but there's no law supporting us for termination of a lethal disorder when the mother has lost 3 kids before and she has another one, then there's a neurodegenerative disease or there's a metabolic lethal disease. So we don't have a law supporting us. So really, I don't even use the word termination in my counseling. It's just have to discuss it with the family and leave. They understand it. They have this option.
Actually,
you are
I
there.
would
Yeah, Dr.
say,
Muneem would be able to. Yeah.
yeah, the thing is that what I was trying to make a point was that when we offer nuchal translucency screening, many times people would say कि ये बहुत ज़्यादा है न्यूकल और फिर जाहिर है इसमें कुछ होने वाला नहीं है. And I'm not saying this just for the heck of it. I'm saying this because a lot of people come to me for counseling, and I do my non-directive counseling. And even before the diagnostic tests are offered, one cannot, and I agree that the law doesn't support termination, but the terminations are done up to 20 weeks of gestation in Pakistan only.
No. I'm
So,
not talking about your comment. I was talking about the lecturer's comment, because Dr. Saab in his lecture said कि Pakistan में बहुत जल्दी termination बता देते हैं before. So I was saying हम तो कह ही नहीं सकते. ये use
नहीं
करना
कह नहीं
word is
सकते.
very difficult for us, because
जी.
legally we are not allowed to.
No,
नहीं वो
I'll
तो
take
फिर
it
जाहिर है
back.
उनसे फैसला होता है ना, नॉन डायरेक्टिव काउंसलिंग ही होती है, and you respect the
Yeah.
wishes of
I
the
totally agree.
parents
I
as
agree.
well.
Yeah.
Yeah.
I really don't know the ground reality in Pakistan because I've not worked there. मगर मुझे ये अंदाजा था कि वहाँ पे पेशेंट्स पूछते हैं डॉक्टर से कि आप बताएं डॉक्टर साहब मैं क्या करूं. And
नहीं
normally,
हाँ,
you
ये
know,
तो
हम
है,
नहीं कह
ये तो
सकते,
है.
हम नहीं कह सकते.
वो
Ijaz,
ये-
I will back you up, because the thing is that all the patients that Ijaz and I have seen together, we always have this conversation with the patients, and the patients tell us that Falan doctor, and they give names, even though we don't even know them, they will give names like Falan doctor from Falan hospital on Falan date told us to have a termination, so we had a termination. Or Falan doctor from this hospital at that date told us that 5 out or 4 out of 1 child that will have this disease. So we ended up having 4 babies. All 4 of them have it. And so, come across those.
I know. I totally
Are
agree.
gonna
Yeah. We don't have genetic counselors now. You're doing a good job. You should produce one for us, because all of us, like, in 1 year, we have done 275 CVS. I was counting because we wanted to publish it. And we don't have genetic counselors. So क्या हम वो mini counselors बने होते हैं? Really, we are not trained to counsel, but we are trying to compensate. So इसी तरह वो इधर उधर से जो भी बेचारे trained नहीं भी हैं, वो इसी तरह की बातें सुन के आते हैं कि आपके 4 में से एक बच्चे में. That's ridiculous, but this happens. It happens because we don't have trained people.
Right. Well, of course, we are very respectful of all the work that you guys are putting in. I've seen Dr. Sharma do some amazing work, and Dr. Sharma, you are doing some fantastic work as well. And we're just trying to do our little bit of a piece of whatever we can. Thank you for your support.
Thank you for your support and taking out time for us.
The next question I have is from Mutahid Shah, and he wants to know, is there any work start on genetic counseling program at Pakistan? And Ijaz, you'd like to take this one?
Yeah, we are trying our best. We have done the survey of different institutions that are there who could support such a program. And we are in talks with Tumne Khan se bhi baat ki, and we've talked to University of Health Sciences Lahore with Dr. Saqib. what we are doing is we are in the process of creating such a program and getting the curriculum in place and all of that stuff. So inshallah, it's coming, where we will announce at a certain time कि कहाँ पे start होगा program. But some program will inshallah start. Dua करें आप लोग सब लोग कि we can get this all together and get it approved by the Higher Education Commission so that they approve the program as well. And then we'll have a master's program for genetic counseling in Pakistan, inshallah, within a couple of years or so.
The next question is from Muhammad Ayman Shahzad, and they want to know which is the more common and safe method of getting the fetus DNA for prenatal testing, CVS or amniocentesis.
So you want me to take this, Ijaz?
Sure.
So, the thing is that if you can do safe amniocentesis, like say 13 weeks, 12 weeks, 13, 14 weeks, that probably gives you higher probability of fetal cells. But if you do CVS, say at 11 weeks, 9 weeks, or 10 weeks, you still have higher chance of having maternal villi or a piece of villi, which if you grow in culture, you will have a problem. If it's a male fetus, then that it's a fetus, but if female, it's always hard. So in CVS cases, we always do what you call a maternal contamination or maternal cell contamination studies before we do any prenatal test. Because in my opinion, amniocentesis is a safer and better or more reliable place to get fetal DNA.
Yeah, and logistically speaking, again, I'm only talking about my experience here in the US. Logistically speaking, by the time we get the results back from, let's say, first screening test that's abnormal, then the second screening, which is typically an NIPT screening, by the time we get to those results back, it's the window of opportunity to have CVS is passed. And so we are typically only doing amniocentesis. And also we know that the risk of miscarriages tend to be a little bit higher for CVSs than for amnio. You were asking about safe methods. So it's again, 1 in 350 chances for a miscarriage, which is again low, but seem to be just a tad bit higher for CVSs than for amnios. The next question. Yeah, Dr.
Can I just say disagree
yes.
a little bit? I would tend to disagree because in the hands of expert, both amnio and CVS have equal risk of miscarriage, which is 0.5%. And I tend to go by my preference. What I think is if you want to have a CVS, you get the DNA quickly, but in amnio, you have to culture the cells. I mean, this is what in Pakistan, and you have to wait longer. So it depends on the choice. If you are doing anti-nuchal translucency at 12 weeks, it's much easier to take the DNA there and then send it off.
Yeah, that sounds great. Thank you. The next question is from Anika Ijaz, and she wants to know, why do we have to confirm next-gen sequencing screening results with the older techniques? I believe NGS stands, she said confirm NGS screening, and I
can take
okay.
that.
I think they're talking about confirming with Sanger sequencing if you have a hit on the NGS. Go ahead, Dr. Rizwan.
Okay, so it's a good point that there are new techniques where we use it for like NIPT and like others, where we use next-gen sequencing as a screening test. So remember the reason we call something a screening test, because we believe there is a high false positive rate in that. But when we call something a diagnostic test, that high false positive rate and false negative rate falls down tremendously. That's why it doesn't depend. It doesn't depend on the methodology, but the yield of the test, that how informative and how accurate the testing is.
Mm-hmm. The next question is from Sayed Mohammed, and he wants to know how to reduce turnover time for prenatal tissue culture.
How to reduce turnaround time for the, I think one is logistics in terms of how quickly you get it to the lab. But once they are in the lab and they are processed, then I don't know, Dr. Naeem, maybe you'll be able to answer. It's a whole process of culturing the cells, and you have to just give them time, feed them, and let them grow. There's no shortcuts to that. The logistics is important. That's about it.
For the sake of time, Dr. Rizwan, if you want to take a quick minute to answer that, and I'll go through some of the other questions that have been coming on. We have a few more.
He may be muted.
Okay, so the next
I missed
question-
that question. I missed that question. Sorry.
Okay, I'll repeat. How to reduce the turnover time for prenatal tissue culture?
Right. So that's again a very good question. So amniocentesis may gives you a better yield of fetal DNA, more confidence of fetal cells, but it will take 7 to 8 days, up to 10 days to grow amniotic fluid cells. But in CVS, you are dependent on checking villi if they are really villi or hydrops or maternal contamination, how much maternal cells you may have. So even if you extract your DNA early, it doesn't mean that you're extracting pure high quality fetal DNA. You may have a lot of maternal cell contamination, which can give you false results in testing, screening, and diagnostic testing.
Okay, the next question is from Farhan Bukhari, and Farhan wants to know for in vitro fertilization, how easy and valuable is it to screen for aneuploidies or pre-implantation genetic diagnosis?
It's dependent on the techniques and the people who are doing it. It's a pretty good technique where they can take a cell out at the 8 cell modular stage. And there are labs that are very good that they can check for aneuploidy, and depending on what genetic disorder you're looking for, some genes are a little bit difficult and tricky, and the laboratory will tell you that if they have what level of confidence they have if the baby is affected or not. But over here I have seen some really good results. I don't work in those laboratories, so I really don't know, but I've just seen the reports that I get from the patients, and they do a pretty good job in telling us exactly what's wrong with the baby, or if there's any aneuploidy or not.
Yeah. Okay, next or last question, I should say, for the evening is from Dr. Saqib Mahmood, and he wants to know, do we need to culture amniotic cells before extracting DNA from them? And I think that's a money question.
Rizwan here again. We do direct DNA extraction from uncultured cell. So
Yeah.
it depends on technique, lab to lab. Some labs have to do cultured, some labs do not do culture. And we are very comfortable in doing extracting DNA from uncultured cells.
Yeah, cultured cell का फायदा ये होता है कि you have a dish of cells growing, so you can do karyotyping. With the uncultured cells extracting DNA, you can just go to direct microarray, but you can't do a full karyotype. For karyotype, you have to grow the cells, so you break the cells and all of that stuff, and do that. So that's an advantage of. So many times what they do is they have a couple of tubes that like Dr. Muneem would extract, and one would be sent for culture, and the other could be sent directly for DNA extraction if time is of essence. So you can actually do both things together and have some cells growing on the side just in case, and you can hold the cells as well for future if something comes back on this. So there are different things that you can do with it. It shouldn't be either or, it can be both.
Perfect. And with that, we will conclude our conversation for the day. What a lovely and exciting and amazing time it is to be part of genetics. And again, I want to say thank you to Dr. Ijaz for doing such a fabulous job on his talk, and his colleagues that helped with the slide deck. And also thank you to Dr. Rizwan, Dr. Shama Munim, Dr. Hafsa, Dr. Hama. Sorry if I missed anybody. But please take a minute to fill out the form that I just reposted into the chat box, and make sure that you fill it out and give us your feedback, give us your input, because that's what we take back to the drawing boards and figure out what to do next. And there's tons to do. So we're all very, very excited and passionate about this. Thanks once again.
I would add a shout out for Aisha and Myla, who is not here today. They are the ones who are navigating the ship very well so far, and wonderful work, Aisha.
Yes.
Thank you.
Thank you
I'll
so
just-
much. Thank you so much.
Thank you.
Well, thank you very much and have a pleasant evening. Khudafis.
Love.